Hi, good morning, and welcome to this tutorial on drug-induced liver injury in both drug-sensitive TB patients as well as drug-resistant TB patients. I'm Dr. Muller. I'm a family physician working at Nkobela TB Hospital in the Eastern Cape. So we're going to have a case that we will be following through, but I'm using it mostly to try and demonstrate an approach you will take when you have a patient with a drug-induced liver injury. And in South Africa, because we have a lot of patients on both TB treatment and HIV medicines, it's a common problem that you'll have somebody presenting, for example, Mr. MG here, 45 years old, started TB treatment on the 1st of June. On the 15th of June, we start him on ARVs. Our new current ARV regimen there is tenofovir, lamivudine, and dolutegravir. And then a couple of weeks later, he presents unwell, or maybe he is vomiting, or maybe even jaundice. And this is a common dilemma that we see within our patient population. And there are a couple of pitfalls. If one does not manage drug-induced liver injury well from the beginning, these can have very, very poor outcomes. And it's therefore important to try and make sure we are very consequent in our treatment. So in this patient, we obviously did a liver function test, and we see there that ALT is 178, bilirubin of 45, the ALK phos is 172, and gamma GT is 332. And you can see all of the liver functions are disturbed, and we often see this. And that could be confusing, trying to decide how you're going to manage your patient. Now, there's lots of challenges around managing drug-induced liver injury, and our biggest problem is that our patients are on so many different drugs that are all potentially hepatotoxic. And it's sometimes very difficult to know which one is actually causing the problem. And in addition, we do have lots of patients with coexistent viral hepatitis. And of course, once you've started them on ARVs, there's a risk that they might be presenting with an iris at this point as well. But the biggest challenge is differentiating your drug-induced liver injury from a TB hepatitis iris, because they both happen at roughly the same time. So at about 2 to 4 weeks into treatment, your patient is either getting sick because of the drugs causing a toxicity to the liver, or it might be that the TB is temporarily causing more inflammation. And it's very important to differentiate these two early on, because they get managed very, very differently. So here's just a quick table to help us untangle a diagnosis in these patients. So firstly, in drug-induced liver injury, remember, this is a toxic liver. And so the liver is sometimes quite tender, but it's not necessarily enlarged. And they're often jaundiced early on with a little bit of an increased bilirubin. But when you want to look at your liver function test, you're only going to look at the transaminases, and specifically at the ALT. Do not get distracted by the AST, which can be affected, especially in our HIV patients, by lots of different things. The only one you're going to use to tell you whether the liver is toxic is your ALT. If we look at TB iris, in contrast to that, there's more of a tender, potentially hepatomegaly. So imagine you either have a large TB lymphadenopathy that's pressing on this liver and displacing this liver, or you might have an infiltration of TB sitting on the outside, sort of growing into this liver, and therefore it's something that's pressing onto the liver rather than poisoning the liver itself. So jaundice is actually relatively uncommon, or more of a late presentation, and synthetic liver function is actually maintained for a very long time. The liver is still working perfectly well. One of the things that can give you a clue is the fact that there might be other signs that there's a TB iris going on. So either the X-ray picture is getting worse, or the most common iris symptom we see is that the patient's losing weight. So you can see that the inflammation is causing more energy use. And again, when you look at your liver function tests, we're now looking at something that's actually obstructing the liver rather than affecting the liver function. So you're going to look at your cholestatic enzymes, and the two there, that's the one that's the most helpful of the two, is your ALP. So already just looking at your liver function test, just start off by looking at your ALT, your ALP, and your bilirubin, and start trying to get a clue, am I dealing more with a DILI, or am I perhaps dealing with a TB iris? We're going to go through a stepwise approach, and I'm using specifically the approach that was published in 2013 by the HIV Clinician Society, where there was a consensus meeting between lots of experts in South Africa to look specifically at approach for DILI in the South African setting in patients that have got TB HIV co-infection. That is a very, very useful guideline to read. I have the reference at the end of this presentation. What I have done is incorporated the latest advice from the new RIF-resistant clinical guide that came out in November of 2019. So we can also think in terms of drug-resistant TB. And I have adapted some of the information with the help of Professor Graeme Meintjies, specifically on the ARV approach, as we now have new ARVs in the mix. So when you now have your patient, you've got your liver function test, you have to make a diagnosis. At this point, is this DILI, and how severe do I think of this DILI? And how you're going to do that is using just the ALT and the bilirubin level. For the moment, you're going to ignore everything else. The ALP and gamma GT is interesting because it might show you how much involvement there might be of TB in the abdominal area. And often patients with increased ALPs will have a higher tendency to develop a DILI, but that's irrelevant in terms of your treatment approach. You also need to look at if there are any symptoms of hepatitis, and often these are actually related to whether the bilirubin is up. And you can also look for other features of systemic hypersensitivity. So, for example, in drugs like nevirapine or abacavir, there might also have fever or a rash accompanying it. Now, what was helpful with the consensus guideline is they created a very simple definition that anybody in the country can use. And they define DILI as following. So if the ALT is over 120 with symptoms or jaundice, so the patient's unwell and the ALT is over 120, we would call that a DILI. If your patient's completely asymptomatic, but the ALT is over 200, at that point we would also say that ALT is too high, that liver is too toxic, and that will also be classified as a DILI regardless of symptoms. And a third one that they've added in is actually looking just at the total serum bilirubin, and if that is over 40, that's also considered a DILI. So just notice there that if the ALT is therefore under 200, so it's quite high, and the bilirubin is under 40, and the patient's quite well, we would not yet call that a full-blown drug-induced liver injury, although we would have to watch that patient very closely and continue to monitor the ALT every week. We now need to decide how severe it is, and one scenario I just want to mention, they actually call it a mild DILI in the consensus guideline, but it is misleading in terms of management. And these are patients that I'm just going to classify as having isolated jaundice or an isolated hyperbilirubinemia. And what you see is a total bilirubin of over 40, but the ALT is still under 120. And this is specifically in our drug-sensitive TB patients as a reaction due to rifampicin. And a lot of patients with rifampicin actually has this transient hyperbilirubinemia. And this can be managed very simply by just substituting rifampicin until the ALT until that bilirubin is settled. So you manage it quite differently than you would your classic drug-induced liver injury. If the ALT is over 200, but that patient is clinically well, we would call that a moderate DILI, and you could potentially treat those as an outpatient. But severe DILIs is actually anybody that's clinically not well, regardless. If the ALT is over 120 and the patient is sick, we would consider that a severe DILI. A fourth degree is patients who actually have a fulminant hepatitis, and you specifically would then look at what the INR value is, so the INR is increased, and you have patients with symptoms of hepatic encephalopathy. These patients we will not discuss today, as they should not be managed in a district hospital setting. You will be referring those to a regional or tertiary hospital in your area. So Mr. MG, if we just go back to our little story from the beginning, remember that ALT was 178, the bilirubin was 45. You can see where that increased ALP and gamma GTs probably got disseminated TB, which has predisposed him to a bit of a DILI. The ALT is not very high, but that bilirubin is over 45. So because he's symptomatic, he has a bili of over 40, we're actually going to classify that as a severe DILI. And that increased ALP and gamma GT, as I've said, is probably due to our TB. You next have to decide whether you're going to admit your patient. And patients who have got lowish ALTs and are clinically quite well, you don't necessarily have to manage in a hospital setting, although in practice the vast amount we tend to. But anybody who's symptomatic would need to be admitted. But also if they're not able to get back for weekly monitoring of the ALT. So if they're not easily able to either get back to their clinic or to the hospital, if they have an abnormal INR or any signs of fulminant hepatitis, obviously, or a very high ALT. So the asymptomatic DILIs you can do, but you need to make sure you're going to continue seeing that patient every week. You do not want those patients to be vanishing off into the community. The next thing you need to do is make a plan with a TB treatment. And as I've mentioned earlier, because there's so many different hepatotoxic drugs the patient's on, you can't guess which one is causing the problem. And if you continue a patient on the wrong drug because you've guessed which one you think you need to stop, there is a 60% potential mortality in some studies due to hepatotoxicity. So we are very radical in terms of modifying our TB treatment. I've mentioned earlier those patients who just have that isolated jaundice on rifampicin. Those patients is the only exception where you can stop the rifampicin and you're replacing just with moxifloxacin. You continue to do your ALT weekly. As soon as that ALT and bilirubin is settled nicely, patient's not developing a severe DILI, then you will just switch that patient back to rifampicin and they usually rechallenge without any problems. But in your moderate DILIs and your severe DILIs, so those ALTs where your ALT is over 125 and the patient's symptomatic, or the ALT is over 200, you need to stop all your hepatotoxic TB drugs. You need to stop your Bactrim. And we're going to start what we traditionally called a liver-safe regimen. We're going to talk about those in a minute. I personally don't like the name. I'll explain why. And if there's a fulminant hepatitis, you will stop all drugs that patient is on and refer to tertiary care. Holding regimens. I don't like the name liver safe regimen, and the reason why is because it tends to give the impression that there's an alternative regimen you can use for drug-induced liver injury that you can then use which is safer for the liver, and that does not exist. We are using a regimen temporarily while we are waiting for that ALT and bilirubin to settle. And this is very important. We have unfortunately seen patients who were seen at a hospital, discharged on a so-called liver-safe regimen, back to their clinics for continuation of treatment. And that is not good practice, and those patients will not do well. So we have different holding regimens, obviously depending on the regimen that your patient was on. If we look at our patients who is on drug-sensitive TB patients, so they were on Rifafor, our three main drugs that we are concerned about that might be hepatotoxic is PZA, rifampicin, and INH. And there's lots of lovely debates about which of those are actually the most toxic. I think generally there's sort of a colloquial acceptance that PZA, which is the most unpredictable of the three, are probably more toxic, but not everybody agrees that we actually have solid evidence on that. But we tend to be more nervous with PCA Rechallenge than rifampicin and INH. But certainly in the beginning, you cannot guess which one is causing the trouble, and you're going to stop all of those completely. So the holding regimen that we're going to consider has changed. And in the old days, amikacin was the backbone of that regimen. Due to the complications of amikacin in our DRTB regimen, there's a huge sensitivity now around amikacin. And just a word of warning, you cannot use amikacin unless you are monitoring the hearing, even just for a drug-induced liver injury. If your patient develops deafness on amikacin, you will not have any medico-legal leg to stand on if you've not been monitoring. But we do have other drugs available now because of our DRTB regimens, and so the tendency would be to combine your ethambutol and your moxifloxacin, which we've always used, and then you've got three options depending on what you have available. There's taururzidone, which we commonly use, clofazimine, which is also supposed to be a little bit liver heavy, so probably not the first choice. And if they've got a good hemoglobin and you've got linezolid available and you can monitor the HB, then linezolid would also be a very good option. For patients with DRTB, the short regimen, this is the kind of thing you'll probably also look up. It gets a little bit more complicated, but you can see the drugs there that we're concerned about is our PZA and our high-dose INH. much lesser extent your clofazimine. But bedaquiline is one of those dark horses where we simply don't know. We did not have enough phase 3 trials when we rolled it out under the compassionate use program, and therefore we tend to try and be a little bit careful with our bedaquiline. So what we want to do is we want to keep our patient on an inadequate regimen for the shortest period of time, and therefore the recommended 3 drugs is linezolid, moxifloxacin, and delamanid. Ethambutol is still also an option, although not mentioned in the guideline. And of course, this will depend on if you have delamanid as an option. Quite often, these patients might have to be admitted to one of your large central hospitals. For our long regimen, it's actually much easier because we don't have PZA or INH in that regimen. And both clofazimine and bedaquiline is not considered to be that toxic. It's more of a we're not so sure. So the same holding regimen is recommended, linezolid, moxifloxacin, and delamanid, but what could also add taururzidone in your moderate DILIs. I would not be too concerned with your XDR-TB regimen. You also have your delamanid, linezolid, taururzidone here as an option. You just don't have moxifloxacin as an option, but these patients will certainly be managed in a central area. I must say we see much less drug-induced liver injury in our MDR and XDR populations than in drug-sensitive TB. It might be that the population of those patients are just much smaller, but also PZA is used much less now, and it's not such a key drug. So in Mr. MG, we would stop his TB treatment, and we're going to put him on a holding regimen in terms of what we have available, which will often be an ethambutol, moxifloxacin, and taururzidone. So let's talk a little bit about ART, which is interesting because our information, our knowledge about ARVs has changed a bit since the 2013 consensus guideline. We still have a lot of patients that will be coming on tenofovir and an efavirenz-based regimen. And the idea is that you want to stop anything that has nevirapine or efavirenz in it. Both those drugs are known to cause hepatotoxicity. In the old days, we used to say you have to cover the tail, but with the new TEE preparation, that's been shown to not be an issue, as the FTC also, the emitricitabine also has a lovely long half-life, similarly to the tenofovir. But the question has been a little bit around TLD, and when TLD was first rolled out, it's a drug primarily excreted by the kidneys, it was thought to not be an issue. But there's been 2 cases written up of very specific dolutegravir-induced hepatotoxicity, and so it's much, much safer than efavirenz, but at the moment, just to not cause any confusion, it will also probably be prudent to stop your tenofovir, lamivudine, dolutegravir preparation. You might also have patients that are on PI regimens. And remember, if they are on a PI-containing regimen and they're on rifampicin, they're probably on the double dose of Eluvia. And in those patients, we will also be stopping all of that treatment. That Eluvia is quite heavy on the liver. Now, in the current guidelines, if we're starting patients newly on TB treatment, the actual recommended ARV is the TEE, because you do not need to boost the dolutegravir, you need to boost, so they're suddenly on twice daily medication. So what will tend to happen is that a lot of patients started on TB treatment will often also be started on an efavirenz-based regimen. So also in the old guideline, it used to be said, well, it's very unlikely to see efavirenz hepatotoxicity after 6 months, and therefore, if they've been on ARVs for a long time, especially on efavirenz, you can just simply continue. That has been taken into question now, and there's definitely been described efavirenz hepatotoxicity after 6 months. So I think in general, just to be safe, you will probably stop the ARVs while you sort out the DILI. Of course, remember to discontinue any other drugs that are toxic. Tramoxazole is classic, and they might even be on fluconazole. Fluconazole, you really have to look at the scenario in terms of how long they've been on it and when they had their episode of cryptococcal meningitis, and you might have to discuss with an expert depending on the severity of the DILI. So in Mr. MG, we're going to have to stop his ARVs, and we're going to have to stop his Bactrim as well. What we now want to do is we now want to monitor, and the reason why we're monitoring regularly is because we want to be able to rechallenge as quickly as possible and keep somebody on an inadequate regimen for the shortest possible period of time. And we only need to monitor the ALT and BILI, save our government a bit of money, And you're going to repeat that every 1 to 3 days as an inpatient, and if they're an outpatient, you'll probably do that weekly. If they have fulminant hepatitis, you also have to monitor the INR, but as I said earlier, please don't manage that patient in your hospital. And once the ALT is under 100, so it doesn't have to be normal, and the guideline says the DILI normalized, but at least under 40, you're going to start looking at Rechallenge. We do find that the bilirubin tends to take a long time to settle, and we would therefore not wait for it to be completely normal. If the ALT takes a really long time, and especially in patients who's got quite a bit of TB of the liver as well, and the patient's otherwise well, asymptomatic, bilirubin looking nice, you can also rechallenge if that ALT is under 150. So when we rechallenge, the principle is simple. You start off with you start treating the condition that's most likely to kill the patient first. So in this scenario, that's why we rechallenge with the TB drugs first, because that's where the patient's most at need. Next, you can start your ARVs, and then any prophylaxis only after that. And of course, every time you're rechallenging a new drug, you're going to check your ALT within 3 days to make sure it's not having an effect on the liver. What's interesting in looking at Rechallenge is that it takes about, the average days is about 18 days, but look at that range there. So probably from about 8 days to about 30 days for that ALT to settle down. So it can take a good month. And there has been lots of trials to look at how should you introduce the drugs, give them all at the same time, start on lower dosages, which ones should you start first. It actually makes no difference in terms of recurrence of hepatotoxicity. The reason why we do a stepwise introduction of drugs is simply to be able to identify which drug might be causing the trouble. And we just start off with the ones that's the most important. There's no other mystical reason of why you do it in a specific way. What's very interesting and very important is that there's only a 10% recurrence rate of hepatotoxicity when you rechallenge. And that was in trials even when they rechallenge with PZA, which we will talk about a little bit. So most of our patients are actually going to do very well. This is the classic rechallenge that we use for drug-sensitive TB treatment. And you'll notice there that we start with rifampicin simply because it's the most important. After 3 days, you check your ALT. Then you add your INH because that's your second most important. And at this point, your patient is now already on rifampicin, INH, ethambutol, plus your holding regimen drugs. You're going to check the ALT 3 days after that. Now, if that all seems fine, you're going to decide about PZA. We'll talk about that in the next slide. And once you've rechallenged all the drugs you're going to rechallenge, you will stop your moxifloxacin, taurursodione, clofazimine, any of the holding regimen drugs that you've been using. And you'll obviously continue to monitor that ALT weekly for at least 4 weeks after your rechallenge. So PZA is interesting because there's different considerations for how toxic PZA really is. In practice, most people you will be able to rechallenge PZA quite successfully. There's still a feeling that that one is the most unpredictable in terms of causing recurrences of hepatotoxicity. So in fulminant hepatitis, people will even be nervous about rechallenging INH and PZA, and there'll be different regimens that you would probably discuss with what will be done by your regional hospital. But if patients has a DILI within early of their treatment of that RIFA4, you will have to decide about what you're going to do with that PZA. And in some cases, you might decide it's worth the risk. So if you've got somebody who's only recently been started on TB treatment and they're really sick from a TB point of view, so they've either got TBM or they've got disseminated TB, it would be really useful to have PZA in the mix. Then you can rechallenge them, and obviously you'll do that in a hospital setting where you can keep an eye on that ALT. But you might also have a scenario where the patient's already had 6 weeks or 7 weeks of their intensive phase. Remember, we're going to be stopping the PZA anyway at 2 months, and in those patients, you certainly won't even consider using PZA again. In MDR TB treatment, again, the same principle applies. You start with your most important drugs, bedaquiline, most certainly our key drug. As soon as that ALT is settling, you're going to restart the bedaquiline, clofazimine if you have discontinued it, and you can certainly try to rechallenge INH. But as PZA is not a key drug, we often discontinue it even if there's an adverse event. It does not actually affect the use of your regimen. We would not use it in our MDR short regimens. Long regimens, we just need to rechallenge the bedaquiline and the clofazimine. That's actually very easy. And the same with the XDR-TB. You're going to put back your bedaquiline and your clofazimine, and you will not use PZA or INH. Once you've restarted whatever regimen you're now going to use, you have to decide how long you're going to give TB treatment. And what we tend to do is we ignore that time before. So we ignore that time that the patient was on the holding regimen, and we're going to ignore the time before that. So if the patient was started having a DILI 6 weeks after he started his treatment, we're going to ignore that first 6 weeks. By the time he's also tolerating, say, rifampicin, INH, ethambutol, from that moment, we will now consider the start of his treatment date. Now, depending on your rechallenge, you might discover that, either I'm not going to use PZA, or you might put the patient on rifampicin and the ALT jumps up, and you realize, okay, we're not going to be able to use rifampicin in this patient. And there's very set regimens recommended. So, for example, and you'll probably just look these up, you don't have to remember these, but if you cannot use PZA, then we give rifampicin, ethambutol, and INH for 9 months. If you don't use INH, then you'll give a rifampicin, ethambutol, moxifloxacin for 12 months. And in a scenario like that, you'll probably try and see if you can put PZA into the mix as well. And if you cannot use rifampicin, then we will probably just use the MDR-TB short regimen without the PZA. For your MDR-TB for the short regimen, if you either cannot use PZA or INH, you can just extend your bedaquiline also to cover. If you cannot use bedaquiline, clofazimine, or linezolid for any reason, then you're going to use your long modified regimens. I've never actually been in a scenario where we've not been able to successfully rechallenge bedaquiline or clofazimine. And with your long regimen, similarly, if once you've successfully rechallenged, you're gonna count that from that rechallenge date of that bedaquiline. And again, I've never had problems with rechallenge of either bedaquiline and clofazimine. If for some reason those drugs are not tolerated, you will discuss it with one of your experts, and we would probably use delaminate instead. So Mr. MG, we're now monitoring, and every nice and week, and his ALT is settling beautifully. Eventually the ALT is 75, the bilirubin is 22, not quite normal yet, but significantly better. He feels very well. And we start off with rechallenging him with that rifampicin. So remember, he'll be on ethambutol, moxifloxacin, and taurursodone already. Day 4, his ALT was 66. Looks fine, so we give him some INH. Now your rifampicin and INH, you can give the combination tablet. Just a word here, there's sometimes you might have a scenario where you don't have single dose rifampicin in your hospital, but single dose INH is much more available. There's absolutely no worries in terms of rechallenging with INH first, because you have a single dose of that, and then when you introduce the rifampicin, you just switch onto Refiner. So that's another way that you can do it if you don't have single rifampicin. Now that he's still on his holding regimen as well, we do our 8 ALT result at 72. At this point, he's now on rifampicin, ethambutol, and INH, and we're going to stop our moxifloxacin and taurursodone at this point. And we still tend to not give PZA if it's not absolutely necessary. So this patient will be on Refiner, which is your combination of rifampicin and INH, and your ethambutol for 9 months. And the start date is that date when we successfully rechallenged that INH. So MDR, I'm not actually going to cover that slide. It will be in the slides if you are interested. It's in the guidelines in terms of what we do when bedaquiline or clofazimine or those drugs are not tolerated. So rechallenging ART, and this is interesting, and we actually, when we did our webinar discussion, we had a very vigorous debate about the use of what we do with ARVs, so much so that I decided to write to some of the profs to give us some guidance on that. And Prof Graeme Meintjies actually met up with a group of his colleagues to actually look and carefully think this through and give us some very clear evidence-based guidance. So we're very grateful to that, and that is what I'm basing this on. So if your patient was on an efavirenz-based regimen before you when you discontinued his treatment, and his viral load was LDL before he had his DILI, then you're not going to rechallenge with TFE, and you're going to just rechallenge him on the new tenofovir, lamivudine, dolutegravir combination. And remember, if they're on rifampicin, you've got to double the dose of the dolutegravir. So he'll have dolutegravir. If he has his TLD at night, he will have dolutegravir 50 milligrams in the morning. But if the patient was on TFE before you discontinued, or on TFN, and he was virally not suppressed, so there's a risk that he might have had resistance to either tenofovir or your amitriptyline, then it might be good to just rechallenge with a new second line. And the new second line is much easier to use than the old second line. It's not even that many tablets. Dolutegravir is a nice tough drug. So AZT, 3TC, and dolutegravir. And remember to double the dose of the dolutegravir if on rifampicin. Now, if the patient was on a Luvia-based regimen, so remember if they're on rifampicin, they're supposed to go back onto double dosing of the Illuvia. It's quite heavy on somebody who's just been through a liver hepatotoxicity. Traditionally, we would rechallenge those drugs. You would sort of slowly rechallenge the Illuvia over a couple of weeks. But do consider here the possibility of changing to a dolutegravir-based second-line regimen. We don't do this routinely. We don't routinely switch people on second line to a dolutegravir-based regimen. So you're going to have a chat with an expert. And it's going to depend on the past viral loads, past NRTI exposure, what's happening with the creatinine, what's happening with the hemoglobin, how likely there is of mutations to some of the other NRTIs. And depending on that, it might be a possibility to put them on a second-line regimen with dolutegravir in the mix there. When you are rechallenging, there are some drugs you cannot ever rechallenge, especially drugs like nevirapine, or if they've got a classic systemic hypersensitivity, like drugs like tramoxazole or abacavir. So they would have been on those drugs and they would have developed the classic fever or rash or systemic symptoms with it. And those drugs you don't want to rechallenge if you knew they were the ones causing the problem. In very severe hepatotoxicity, we'd be very cautious about rechallenging any possible offending drugs, and those with the fulminant hepatitis will be discussed by specialists. Last little word on just tramoxazole. Severe DILI, we don't like to use tramoxazole again, so we tend to use dapsone in those patients. But you might have patients with that previous PJP, wasn't particularly sick with their DILIs, then it's very helpful to rechallenge with your cotramoxazole and just keep an eye on that ALT and that bilirubin. There's my just references. There's the guideline reference. Please just Google it and do download it and read it. And the rifampicin-resistant tuberculosis clinical reference guide has got a chapter on hepatotoxicity. I also would like to just thank again Prof Meintjies for their input on the ARV side, and hopefully at some stage we'll have an updated consensus statement to give us guidance. Drug-induced liver injuries are common. They're one of those things that are a headache if you are in a district hospital setting, but they're actually very satisfying to manage if you have got a good, solid, evidence-based, stepwise approach. Your patient will do well, and you'll always know where you are with your treatment of those patients. Feel free to look at other possible presentations on the channel, and we'll see you for the next tutorial.